Let me welcome you to the topic of smoke evacuation in the operating room. Before we get to this topic, which I think is very pertinent in today's surgical practice, let me briefly introduce myself. My name is Leonard Schultz, and I have been a practicing surgeon for approximately 30 years in the Twin Cities of Minnesota. During that period of time, I've had a special interest in laser surgery. But as you probably know, laser surgery produces a lot of smoke. And the issue became one of trying to find people who could tolerate the amount of smoke in the room during the early days, going back to the 1980s, when laser surgery for vaporization of large tumors was a popular thing to try to do. Out of that interest grew a 30-year journey of trying to find ways to help all of us who work in the operating room to get rid of the smoke that is invariably produced as we do our work. And that's what the story today is all about. We're going to talk about why we should prioritize smoke evacuation in the operating room. And I hope by the end of this conversation, you will believe, as I have for a number of years, that this is an important item, and I hope you'll become strong advocates for the removal of surgical plume from your operating room. So let us begin. So the real question to ask is, why? Why should we remove surgical smoke from the operating room? We have to come up with good reasons. Obviously, if you're a perioperative nurse, the major reason is you don't want to be working in a coal mine all the days of your work. But the real issue has to do with the surgeons who are in and out of your work environment within relatively short periods. And that's what we're going to try to get to in this discussion. Let's go back to the history a little bit. You may recall, some of the older folks here, that we didn't always use electrocautery to do cutting and coagulation. It wasn't until the mid-60s that the Bovie machine was introduced, big as your washing machine, and of course now they're much smaller units as electric generators. But before that, all bleeding was controlled with small clamps, usually called mosquitoes, and some kind of suture material, most commonly catgut. But what the Bovie machine introduced to us was smoke, as well as a fast way of doing surgery. And that smoke had to be dealt with some type of a smoke evacuator system. The earliest one of which was developed by Emil Stackhouse, also in the late 1980s, in which he relied upon a 7/8 inch tube called respiratory tubing, held very close to the source of smoke production. Well, in those old days, we had lots of help around the operating room, and it wasn't hard to find an extra hand to chase after the smoke plume, but that is no longer the situation in today's operating room environment, so we had to come up with something else. In the late 80s into the early 90s, the first smoke capture device was actually a smoke filtering device, which involved, as this picture indicates, simply a housing containing an OPA filter and an activated charcoal disc, and it was used to remove smoke during laparoscopy. Now, normally, one would think that this device was invented to prevent you from breathing in smoke that would be vented through one of the side vents of a trocar. But actually, what it evolved into was a visualization enhancing device, because without the smoke in the abdomen, you could see better and not have to clean the lens. We all know that you take the warm lens out of the abdomen, expose it to the cold air, and then put it back into the abdomen after cleaning it, and now you have condensation on the lens to deal with as well. After this, the next product was primarily for open surgery, and this was what we're all familiar with. This product has been around, the ESU Pencil has been around for about 17 years now, and as you know, is having one modification after another modification to try to improve its acceptability and perhaps its smoke evacuation efficiency. The last product introduced also is a smoke capture device based on an open cell foam, based upon an open cell foam used as an area for capture. The main difference that you will notice immediately is the surface area which this product creates versus the surface area for capture represented by the orifice of a tube. Speaking about differences in surface area brings us now to a great segue into the principles of effective smoke capture. This slide points out that in order to capture smoke effectively, the orifice of the capture device, whether it's a tube or any other device, has to be as close to the source of smoke production as possible. A number of studies done at the University of Minnesota, Department of Mechanical Engineering Particle Calibration Laboratory, where these results were obtained, the results in this slide were obtained, indicate that if you were to keep an open tube, which we call a wand, close to the source of smoke production, as little as 1 inch or 2 inches, the smoke capture efficiency is very high. If you move it back to 3 inches, however, from the source of smoke, the efficiency drops down by half. The next thing that's important is, of course, the strength of the evacuator. The smoke evacuator is a turbine, usually located in a box, that powers the ability of the device, which is, of course, a passive thing. It has no power in and of itself, and brings the smoke away from the operative field. The stronger the smoke evacuator is, that is, the more airflow it can generate, the further will the column of smoke travel. Let me say that again. The more powerful the smoke evacuator in terms of the amount of airflow that it can produce, the further the column of smoke will travel toward the collection or capture device. The minimum amount of airflow necessary to capture smoke is about 25 to 35 cubic feet per minute. Most modern smoke evacuators are capable not only of that much, but even as much as 45 cubic feet per minute or more. This is perfectly adequate to have a high smoke capture efficiency. The next thing of importance is the tubing diameter. As you look over the numbers here, you can see that the smaller the tube, the less airflow can get through it. And the less airflow that can get through the tubing, the less smoke will be captured, because not only do you capture smoke when you use a suction device, but you capture the ambient air around the smoke, which is rapidly rising because it's hot, and rapidly dispersing because of Brownian motion of the molecules going in a random fashion. So the three major principles then are the closeness of the orifice of the capture device to the source of smoke, the strength of the evacuator, and the size of the tubing, bigger is better, the size of the tubing that allows greater airflow. This is another way of saying the same thing that we've read. This graph is saying the same thing that I've just talked about. The bigger the tubing, the more the strength of the smoke evacuator, and the closer the orifice is to the source of smoke, the better will be your smoke capture efficiency. Okay, so we finally get to the good stuff now. Why should we care? What are the real arguments for removing smoke from the operating room? The obvious one is you don't want to breathe it in, but boy, there are a lot more reasons than that. First of all, let's understand that smoke is just one of the poisons that we bring into our body every day. We do it in a number of ways. We absorb poisons through our skin. We breathe them in through inhalation, which is the most common common way that we bring in these poisons, and then we ingest them. When you work in an operating room, be aware that there are various environmental dangers for you to deal with. The obvious one is radiation. Nobody will argue that you need a lead shield around your thyroid when you work around a lot of x-rays, as in orthopedic or spine work, to prevent thyroid cancer. No one will argue that you can use noise suppressors if the operating room you're working within has excessive noise, because we know that chronic exposure to noise levels of 60 decibels or more will result in hearing loss over time. But the third environmental danger is that of surgical plume, and it has both short and long-term health sequelae. First of all, this is what we know about smoke at this particular moment. 1. HPV inhalation, which is human papillomavirus found in venereal warts, can produce adenocarcinomas of the nasopharynx and tonsillar cancer. This is out of the closet, as it were. Now, we can't hide it anymore, and before the last few years, it was always anecdotal, but now, unfortunately, it becomes more and more common. The toxic gases and particulates in smoke, we all know about these. We've been taught this for a number of years now. There are over 600 gases, but the important ones, the ones that NIOSH has said that has both mutagenic and carcinogenic properties, include things like benzene, formaldehyde, various aldehydes. And these are the things we don't want to be breathing in on a consistent basis. The short-term effects. Kay Ball did a research project for her PhD thesis. You may recall that Kay is a past president of AORN. What she found was that the incidence of respiratory illnesses in perioperative nurses is twice that found in the general U.S. population. And of course, you're all familiar with dry eyes, tears, sore throat, and so forth, occasioned by the end of the day. But what are the long-term effects? Well, what we're finding is that the long-term effects are based upon breathing in chronic inhalation of the nanoparticles, which, by the way, comprise 80% of the surgical plume. Breathing in that over a long period of time will result in serious systemic illnesses, depending upon individual genetics, pre-existing illnesses, and the dose duration of exposure. Nanoparticles. These are also called, by the way, in the medical literature, ultrafine particles. You don't hear very much about these. I have not heard anything in the surgical literature, read anything in the surgical literature about nanoparticles, except for one German article that measured nanoparticles in the operating room during various operative procedures. What that article stated was that the nanoparticles remain in high concentration despite the ventilation systems normally present in the operating room. In other words, there is a continual increase in the nanoparticles coming from the smoke during the operative procedure. Now, nanoparticles are particles of less than 1/10 of a micron. 100 nanometers equal 1/10 of a micron. Why do I bring this up? Well, because the filters, the OPA filters that we all know about, say that you have a 99.99% protection against particles down to 0.2 or 0.3. What we're trying to say is that nanoparticles can get by OPA filters. And that's why, and we certainly know, by the way, before I forget, we certainly know that surgical masks are not protecting you against breathing in, breathing in nanoparticles. I first found out about the term nanoparticles as a result of the research at the University of Minnesota when the individual who was carrying out the experiment sent me this graph. And in this graph, this was the one that pointed out to me that 80% of the plume that we were investigating, that was being investigated, were nanoparticles. Before that, I had never heard, in 30 years of practice, had never heard of a nanoparticle in the surgical literature. but I soon found out about them, and this is the article that I recommend you go to try to find out the effects of nanoparticles on your individual health. Pretty scary stuff. The life cycle of inhaled nanoparticles. Now, obviously, we breathe these in every day, all of our lives. We've been doing it for forever. But the process is one of neutralization. In other words, most of the nanoparticles that you breathe in get all the way down to the alveoli and are there neutralized by a process of phagocytosis as a result of the action of macrophages. This neutralized material eventually becomes known as phlegm, moves up the respiratory tract by a process known as a mucociliary elevator. Forget that term, you'll never use it. It then goes right into your esophagus and is excreted as part of the stool. But what happens when there's an accumulation of certain size nanoparticles, the 20 to 80 nanoparticle size? That's the critical part, because those can concentrate in the alveoli because the macrophages are not quite as efficient at neutralizing them. Should they accumulate in sufficient amounts, they can pass through the alveolar membrane through a process called translocation, enter into the arterial lymphatic system, and go to all organs of the body. Therefore, you should not be surprised to hear that the first responders to 9/11, 10 years after the event, now have cancers in their liver and lymph nodes. How do you think those materials, and remember, they had an acute, overwhelming, toxic experience with inhaled nanoparticles as a result of them being first responders. Chronic inhalation of nanoparticles has been found to be associated with various serious systemic illnesses. Among them are neurodegenerative diseases such as Parkinsonism and Alzheimer's, as well as cardiac diseases such as coronary artery disease and cardiac arrhythmias. And while I'm going through this list, I want you to think about other people that you've worked with in the operating room who have come up with these diseases, not after 1 or 2 years of exposure, but working for 10 or 20 years or more. Other diseases include collagen diseases, such as systemic lupus or rheumatoid arthritis, as well as various cancers, which include breast, pancreatic, and prostate cancer. All of these are really based upon what is known as the oxidative stress caused by nanoparticles, which literally attack mitochondria in the cell and interfere with their oxygenation. Now, after stating all these things about chronic inhalation, let's understand that you're not, if you were to be an advocate, you are not standing alone. OSHA has clearly declared that the employers are responsible for the health of their employees. And this includes both materials, such as masks and so forth, and gowns and that sort of thing. But they have to know that they are responsible for removing carcinogens from the operating room. And as we found out from NIOSH, and we'll get into this in a minute, NIOSH, the research arm of OSHA, has already indicated that the contents of surgical plume are both mutagenic and carcinogenic, and related this in what is known as warning letter number 11. This slide indicates what we've talked about just briefly, called the general duty clause and the respiratory clause. I'm sure many of you are very familiar with this. The OSHA standards, this is very interesting. In approximately the year 2000, a medical device company that sold smoke evacuators asked OSHA whether or not the bloodborne pathogen rule covers the inhalation of smoke, and does it offer a mandate for protection from that inhalation of smoke. OSHA responded that it did not, that the bloodborne pathogen rule does not cover this. But when you look at this slide and read it, it doesn't really make much sense. The reason why is because that bloodborne pathogen rule says that the perioperative team has to be protected against blood spatter. So we have protective shields for our faces, and we can't get any of the blood on mucous membranes because of its potentially infected material. Excuse me? Potentially infected material as a liquid. We're talking about the same blood found in the surgical plume that comes from the very same individual with the very same fluid, which is now in the form of a vapor that you freely breathe in through your mask. Yet you're protected when it's a liquid instead of a vapor, a gas form. Makes absolutely no sense. But be aware, the bloodborne pathogen rule protects you against blood, but not another form in which you take it into your body. We mentioned NIOSH says get rid of smoke. It's potentially mutagenic and carcinogenic. AORN, your professional organization, makes no distinction between electrosurgical smoke and laser smoke and says get rid of it with local exhaust ventilation machines, commonly referred to as smoke evacuators. Your Joint Commission says the same thing. In other words, the hospitals are well aware that they should have an active program for removal of surgical plume from your work environment. The question is, will they do it? And I think right now the trend is starting to change from kind of keeping the evacuators off in the closet to finally getting people to realize the importance of to their long-term health and starting to use smoke evacuation technology. The industry response we've really spoken about. The wand or the tube, and now the wand, as you can see in this photograph, really has evolved into a 7/8 inch corrugated hose called respiratory tubing with a sieve over it to prevent the possibility of a sponge being sucked into the tubing. Again, this was the original way in which smoke was captured. The problem with it is that it requires somebody to do it, and we don't have a free hand in the operating room anymore. The ESU Pencil. This is a monopolar electrode with either an attached or an embedded 3/8 inch tubing attached to it, with the tip of the tubing as close to the tip of the electrode as possible to gain maximum efficiency. Normally this product is attached to a wall suction, which gains about up to 5 to 9 cubic feet per minute of airflow, or now it's more commonly being attached to smoke evacuators, which increases its airflow to as much as 15 cubic feet per minute or more. However, the size of the tubing, if you remember principles of smoke evacuation, the size of the tubing limits the airflow, and so it is not surprising that smoke capture efficiency may be compromised. And then the cell phone-based device with a much wider surface area for capture. This is a comparison of these various capture devices, again based upon research data conducted at the University of Minnesota, in which the comparison was made of the wand, the electrosurgical unit pencil, and the cell phone technology. And you can see under the average smoke capture efficiency, very high for the wand, and especially therefore makes it useful for mini incisions where you can just attach it to the drape within 1 or 2 inches from the smoke source. The electrosurgical unit pencil, because by putting the tip of the tubing very close to the tip of the electrode and sometimes obscuring the vision of the surgeon, they pull it back to about 1 inch, 1.5 inches, at which time the smoke capture efficiency decreases. Whatever the reason is, these were the established numbers from the study. And then the cell phone technology, which is quite high. In all cases, it is a disposable product. Hand fatigue has been mentioned about wand and electrosurgical unit pencil, but you can read the rest of it yourself. Smoke evacuators. They're either desktop or standalone. They rely upon OPA filters for their filtration. There is, however, an alternative to these individual units, and that is a central vacuum system. And personally, I believe that this is where we will eventually go in the process of smoke evacuation for a very simple reason. Once installed, they no longer need OPA filters. And it's no secret that OPA filters are the most expensive part of a smoke evacuation program. And these central smoke evacuation systems, these central vacuum systems, actually pay for themselves, usually within 2 years of installation. This is a very clever idea. The Stryker units, which are combined fluid management and smoke evacuation systems, probably the most popular unit that we've run across as we visit various hospitals around the country. OPA filters. OPA filters are individual units usually encased in a plastic housing. They consist of pre-filter material. The OPA filter material itself, which is most commonly microfibers of glass, and this is the material that absorbs the particulates that come through and that pass through it, followed by activated charcoal, which absorbs the odors and the chemicals themselves, and finally they may have a post filter as well. Now, the question is whether or not OPA filters actually protect you as much as you think they do. Now, the specifications say 99.999% efficient for materials down to about, I think we said 0.2 of a micron, 0.2 microns. The problem, however, is that the specifications for OPA filters were developed for face masks, N95, which means that the airflows were much lower than the airflows that they meet in the operating room, 10 times lower, so that the speed at which the air the smoke will pass through the filter is much faster. And even with the process, the phenomenon known as diffusion that tends to absorb more and more of these nanoparticles, as you can see, the measured amounts of nanoparticles that get through OPA filters is much greater than you would expect. Actually, about 5 to 10% of these nanoparticles can actually pass through the OPA filters. And this is another reason why I believe that central vacuum systems will win. The next thing that we want to talk about is, can effective smoke evacuation, can it prevent bacterial contamination in the operating room? To date, we don't have any solid evidence in clinical studies to say one way or the other, but what we do know is that surgical site infections remain a problem. Overall, about 2 to 3% of surgical procedures, and they're expensive to treat. And of course now the federal system, Health and Human Services, says if you have a wound infection within 30 days and you need readmission, that's your problem, Mr. Hospital and doctor. It's not our problem anymore because we're not paying for it. Well, this is what I call an example of unintended consequences. After working so hard to develop MIS, minimally invasive surgery, in which patients come in and then go home and then are seen in the doctor's offices instead of staying in the hospital where their wounds are examined and checked for any temperature elevation or redness around the wound where contaminated fluid can be let out with a simple mosquito. Now they go home and aren't seen for a week or two, and by that time a wound infection could be considerable. Look at all the things that we have tried to do to get rid of infections. From shaving and not shaving, to scrubbing, wound barrier drapes, with or without bactericidal materials in it, various regimens of antibiotics, different methods of wound closure with absorbable materials and non-absorbable materials. The list goes on. And let us not forget pre and post nutrition. We've tried these spacesuits. We've tried the laminar flow rooms. None of these things have really worked to get down wound infection. So we're at a point now where we're looking for something that we're missing. What are we missing here? Because what we do know is that if you have a barrier between smoke and the open surgical wound, wound infection rates are diminished. We also know that our tissue is not sterile. We know that 70 to 80% of all wound infections come from the bacteria within the patient themselves. So we develop an hypothesis for the cause of surgical site infections. And here's the hypothesis. Perhaps the electrosurgery, the process of electrosurgery itself, releases the patient's viable bacteria into the smoke. Because have you ever asked the question, how did all those bacteria get all over the operating room? Why do we find the bacteria in the ceiling? Why do we find it on the cabinets, the walls, the tables, the floors? The only way those bacteria really could get around all these places is if it were carried by the smoke. And that's the hypothesis, that bacteria are released by the process of electrosurgery, enter into the smoke where they remain viable, and then are carried to all portions of the operating room, which could include the back table and your Mayo stand, which are areas that you think contain sterile instrumentation. It therefore goes that if we could capture those bacteria that are released in the smoke, could we then prevent bacterial aerosolization and perhaps contamination of a surgical wound? To answer this question, a laboratory called Biotest Laboratories, a division of Steris Corporation, here in Brooklyn Park, Minnesota, was asked that question. And they developed a protocol and did the experiments within a sterile plexiglass container called a glove box, which measured approximately 4 feet long and 1.5 feet high. And what you're looking at is a photograph of the experimental setup through the plexiglass. At the center is sterile pork, which was sterilized with gamma radiation and impregnated with Serratia marcescens. Around it are 4 sterile agar plates for culture. And to the right, although not numbered, is another sterile agar plate that's put on a micropore sampler, which is a little suction device that pulls any environmental air or smoke in toward the plate, which is covered by a metal sieve. This is a schematic of the same experimental setup. And in this particular set of experiments, lasers were used, in this case a CO2 laser. Electrosurgery current was used as full coagulation, and then a blended current, which is what most of us would use in the operating room. There was an LEV, a smoke evacuator, with the reticulated cell foam device, which was placed close to the experimental area. And these are the results of that study. There's a lot of data on this slide, and we'll try to go through it. First, let's see the type of the device used. And then let's go over to the control. The baseline simply says, were there any colonies formed of Serratia marcescens, CFUs, formed in the device itself before we even started the experiment? And the answer is no. And then we used a predecessor of the reticulated cell foam product called Mini-Square, called Square. That was used, and then 2 other experiments. So these experiments were repeated 3 times. And in each instance, when the CO2 laser was used, no colonies were formed. Well, when you think about it, years ago, this laser was used actually to sterilize wounds that were recalcitrant to the usual methods of debridement and sterilization. And so it was really not surprising that no colonies, no bacteria could survive the effects of the CO2 laser. The same was true of the coagulation cautery. The heat transfer was so great that it killed off the bacteria, and you'll notice again under the controls, no colonies were formed. And these colonies, by the way, we're talking now about the micropore sampler. So in order to form colonies in this control group, the bacteria had to be released into the smoke as a result of these heat transfer devices, and then move the 3 or 4 feet all the way to the sampler where they would possibly grow on the sterile petri dish that was present in the device. As it turned out, the only ones that had too many colonies to count were when we used blended cautery. In other words, the model of using mixed electrocautery, a blended current, would now allow us to study viable bacteria carried by smoke. Another way of saying this is that electrosurgical current in a blended format can produce aerosols filled with bacteria. And that's why TNC, too numerous to count, colonies were formed on that distant petri dish. The next study was to see whether or not the effective smoke evacuation using the squares could produce a diminution in contamination of the simulated surgical wound represented by those 4 petri dishes surrounding the contaminated tissue. In this case, now that we knew that blended electric cautery could produce viable bacteria, only this method was used. What this slide shows is that petri dishes 3 and 4, at positions 3 and 4, had a significant reduction in the amount of colonies counted in contrast to controls and those further away from the smoke capture device. It therefore follows, as a result of this, that what we really need to do is now proceed with a clinical study using effective smoke evacuation to see whether or not we can actually decrease the incidence of surgical wound infection. And that is the conclusion in terms of looking at smoke evacuation as a possible future infection control device. And there are other benefits to effective smoke evacuation. We all know that clean air reduces the incidence of absenteeism. And absenteeism in the operating room has as its second most leading cause respiratory illnesses. We all know that the first is musculoskeletal problems. What effect effective smoke evacuation could have on absentee rates in the operating room and the implications for cost savings is as yet unknown. The other aspect of it is that we know that illnesses in the operating room related to environmental issues have been litigated and won by the litigants, by the claimants. And so the hospitals are, in fact, and the other employers are held responsible for clean, healthful environmental conditions for their employees. In the operating room, there's no question there are certain barriers to its use, and certainly the surgeon resistance is primary. As a previously practicing surgeon, I can tell you that probably the origin of this resistance is that once surgeons establish effective protocols for doing their procedures, they're very loath to introduce any new technology or any new methodology because of concerns about the possible effect that it may have on a successful outcome from their operative procedures. And therefore, any new technology is going to have resistance. And any new mandated protocol, no matter what the method for smoke capture is going to have resistance. So education is really what is needed. And we hope that we're developing better arguments for why surgeons will benefit, not directly, certainly not in terms of revenue or patient accumulation, but rather because of the increased safety of their patients to something such as the incidence of wound infection, postoperative wound infection. The aids, again, education and training. The more you know, the more relaxed you are with the technology, and once you realize that it will not interfere with protocols or the end results of your patients, you tend to say, certainly, I'll accept that. We cannot look toward the government at this point of view to try to see whether state or federal for mandates for the use of smoke evacuation equipment. This has to be a hospital by hospital decision, or now, because so many health systems are gaining more and more hospitals under their purview, it would really be health system by health system. But the smoke capture, or I should say smoke evacuation policies, are what will be necessary to see this happen on a uniform basis within your healthcare facility. And you as nurses, perioperative nurses and techs, and in some cases physicians who understand the value of smoke evacuation, have to become strong advocates for this at the various committee structures that are at the various committees that are necessary to finally win favor. There's no question that the staff themselves need to be well trained in smoke evacuators. I've seen staff in the operating room that really are very unfamiliar with how to best use smoke evacuators and the usefulness of the filters and how to apply or to how to use the devices that we've been talking about. And so we have to have an ongoing policy in the hospitals that try to keep the technology up to date and the knowledge of the nurses up to date. And invariably, as you recall the days of laparoscopy and lasers, doctors would be bringing this technology into the operating room. The nurses said, "What in the world's going on? I have no idea what you're doing." And so the issue of professionalism comes up because the nurses want to do their job well. And the best way to do it is to maintain a consistent training program to introduce the new technologies as they arrive. Compliance will remain the issue until smoke evacuation policies are established hospital-wide. Despite OSHA, Joint Commission, and all the other things we've talked about, compliance has to be based upon a thorough understanding of the reasons why it's not a good idea to have chronic inhalation of nanoparticles present in smoke. And I hope, having gone through this course, that you now understand the reasons for why I say this. I want to thank you for taking the time out to listen to me and to think about all the issues that we brought up, and there are a lot of them. There are psychological issues, issues of education, issues of compliance. It's a big topic, but remember that we have been trying to get smoke out of the operating room for almost 35 years, going back to the mid-1980s. Don't you think it's time? Don't you think as nurses it's time for you to turn to the surgeon and say, you know, you may not want it because you're out of here within an hour or two, but I'm here all day long, and do you really have a right to prevent me from protecting my personal health? Be strong, be consistent, and get the job done. Thank you very much for listening.